So let's look at all the multiple marker screening programs offered and use the detection rate and the screen positive rate in normal women to compare them. The numbers you're going to see during this comparison are those we use here at the FBR, but it's pretty likely that your lab has similar numbers. Some offices wish to confine their Down syndrome screening to less than 13 weeks. This screening involves a combination of serum markers and a measurement of nuchal translucency. As you can see, the detection rate is 86%, but to achieve that rate, you need to use a cutoff that gives a screen positive rate in normal women of 5%. This means you are offering a lot more normal women chorionic villus sampling, or amniocentesis. It's important to note that a blood draw in the second trimester is still needed to screen for open fetal defects. With sequential screening, you achieve a higher detection rate, 89%, and a better screen positive rate of 3%. With sequential screening, if the combination of nuchal translucency measurement and serum markers exceeds the first trimester cutoff, the woman would be identified as screen positive for Down syndrome at that point. But if her testing does not exceed the cutoff, no report is issued. It is a mistake to interpret this as meaning she does not carry a child with Down syndrome, since the markers analyzed after her second blood draw are combined with the results of the marker values from the first trimester to give a result in the second trimester. This is the result shown as giving an 89% detection rate and a 3% screen positive rate. This is the testing your patient had. If you had told her that her first test suggested she was not carrying a Down syndrome baby because you did not receive a positive report from the lab, it would be quite confusing to now explain that her risk of carrying a child with Down syndrome is being reported by the lab as screen positive with a risk of 1 in 110, which is much increased from her age-related risk of 1 in 900 as shown on the report, if you recall that. This occurs with sequential screening since the cutoff for first trimester testing is set quite high so that it only identifies 1% of normal women as positive in order to avoid exposing them to the risks associated with chorionic villus sampling or amniocentesis. But by setting the cutoff that high, women who are actually carrying Down syndrome babies will be missed a certain percentage of time in the first trimester, but picked up in the second trimester. That's what happened with your patient. Full integrated screening uses first and second trimester markers, as well as the nuchal translucency measurement, as does sequential screening, but no report is issued based on the first trimester measurements. This results in slightly improved detection of 90% compared to sequential screening, with the same screen positive rate in normal women of 3%. There is a variation of this integrated first and second trimester multiple marker screening called serum integrated screening that is a good option for practices that cannot obtain measurement of nuchal translucency in their patients. Serum integrated screening gives a detection rate of 85% with the same screen positive rate of 3% seen in full integrated screening, and is definitely a good option. Finally, if a woman does not present to your practice until the second trimester, the quad screening test is available. Because it only uses multiple markers from the second trimester, its performance is not as good as the other testing, and like first trimester screening only, identifies 5% of normal women as screen positive. In summary then, we most often use the combination of first and second trimester multiple marker measurements for Down syndrome screening because we wish to increase the detection and decrease the number of women called screen positive who do not carry a child with Down syndrome. And this increased performance of the testing occurs because some serum markers can detect Down syndrome in only the first or second trimester. So hopefully you now know how to answer your patients and the phlebotomist question about why tests are drawn in the first and second trimester. You also should know why it's not a good idea with sequential screening to imply that not receiving a screen positive report in the first trimester means your patient is not carrying a Down syndrome baby. Check your understanding of the concepts of multiple marker screening for Down syndrome by answering our questions, and then go on to Lesson 4 to hear how our genetic counselor, Jerry Erickson, discusses the next steps after a screen positive report for each of the tests, and find out how your patient's further testing came out.
After listening to each question, pause the video and select your answer. Then listen to see if you are correct. Pick the best screen positive rate for a prenatal screening test from the list below. 3%, 10%, 5%, 1%. The correct answer is D. Some serum markers can assess Down syndrome risk in only the first or second trimester. True or false? The correct answer is true. Testing for Down syndrome in both the first and second trimesters can increase detection and decrease the number of women called screen positive who do not carry a child with Down syndrome. True or false? The correct answer is true. The full integrated screening test has a 90% detection rate. Can a woman with a screen negative test result deliver a baby with Down syndrome? Yes or no? The correct answer is yes. Your office offers prenatal sequential screening. Your patient is having her blood drawn for the Part 2 second trimester test, and you have not received a report for Part 1. This means your patient is not at increased risk for carrying a baby with Down syndrome. Your patient is not at increased risk for carrying a baby with an open fetal defect. Your patient's risk for carrying a baby with Down syndrome will be determined following analysis of her Part 2 sample. Your patient is not at increased risk for carrying a baby with trisomy 18. The correct answer is C.